My name is Vaishali Patel. I'm an attending physician at Mount Sinai Hospital in Manhattan. We're going to be talking about one pill can kill pediatric poisonings. So from this graph, you can see from data reported to the National Poison Data System that in 2015, that there's a huge spike in ingestions for 1 to 2-year-olds. And why does that happen? Because kids find little pills on the ground and they look remarkably like candy. So they pick it up, they eat it. Sweet Tart looks like a cold medication, Jelly Bean looks like an iron, Hershey's looks like an X-Lax, and from there you can sort of see the problems that could happen. This is a list of all these many different ingestions that can occur that can cause significant morbidity in children, where in adults it may not cause too much from a single ingestion, but kids, because of their body mass, one single pill can definitely do some damage. So we're going to just sort of go through a couple of cases to sort of highlight different things that can happen. So first case is a 2-year-old male, comes in with stridor. Her mom was in the usual state of health until about an hour ago, was found playing in the laundry room, noted to be drooling, breathing a little funny. Notable vitals are a pulse of 130. Oops, went too fast. Drooling, stridor, some retractions, has some edematous skins and erythema noted on the chest. So what is this from? The SUDS, single-use detergent sac. These were released in 2010 in the US. There's become a growing number of ingestions. Why? Because if you look at it, it looks a lot like a teething ring. Kid finds it, plays with it, starts eating it. There's significant increased morbidity associated with as compared to non-pods. So what happens to them? It's basically alkalis and acids can cause both liquefactive and coagulation necrosis. The different sites of injury include the GI tract, respiratory tract, eyes, and skin. You get drooling, airway compromise, dysphagia, odynophagia, epigastric pain, and hematemesis. So what do? You can give steroids. As always, steroids are sort of controversial, and there's different data as to whether it's truly beneficial or not, but can't hurt. Secure the airway as needed, appropriate size tube, basic labs, chest X-ray KUB, and endoscopy typically needs to happen within 12 hours of ingestion. What don't we do? We don't ever attempt to neutralize these things because you could potentially cause an exothermic reaction that'll cause more damage. You don't want to use charcoal because it's not really going to absorb to the ingestant, and it may interfere with the endoscopy that needs to happen urgently. And we also don't want to ever put an NG tube in because you don't know what damage has already occurred and you may be causing more damage. So on to the next case. We have a 15-month-old who comes in with seizure activity, has a history of febrile seizures in the past. Mom was in the shower, child was playing in the room. When she comes out, she notices the baby's shaking all over with eyes rolled back, no recent fever, no recent trauma, had a URI last week per the mom. Relevant vitals, pulse of 150, blood pressure 90/72, has active seizure activity going on. They note that the child smells like mint and rosemary and that thick paste is on his chest and face. Glucose is 91. What's the next step? Obviously, you want to treat your seizure. Basically, dealer's choice as to which benzo you want to use to treat it. This is a list of different ingestants that can cause seizures. So you've got the common ones: cocaine, antihistamines, carbon monoxide, cyanide, lead, INH, antidepressants. The list goes on, but these are the most common ones that can cause seizures. So in this case, it's camphor. So camphor's mixed into a lot of sort of over-the-counter remedies that are readily available, that are going to be readily around somebody's house, that may not be as well protected as medications or other things would be. And so kids are more likely to potentially get into them. So for camphor, there's about 13,000 exposures per year. 80% of those happen in kids under 5 years old. The mechanism of action is actually unclear, and ingestion is the most common route of exposure. Typically, the symptoms present within 4 hours of exposure. There's unfortunately no specific testing available for it. Gastric decontamination is not necessarily well studied, and there's no specific antidote, and it's basically just supportive care. And on to our last case. 2-year-old toddler is brought into the ED by the grandmother. Grandmother is concerned that the child may have taken one of her medications. She, of course, cannot remember the list of medications that she's on, but she does note that the child's been a little bit sleepier than usual. Relevant vitals, pulse of 52, blood pressure of 50/38. Baby's a little sleepy, pupils are 1 to 2 millimeters, has periodic breathing, finger sticks 88, EKG shows a sinus brady with a 1st-degree block. So try Narcan, of course. Baby's a little sleepy, might help, pinpoint pupils, doesn't really do much. But a key, you notice that the baby was bradycardic and hypotensive, so what things can cause that? Some type of blocker, alpha, beta, calcium channel, DIG. How do you tell between them all? Beta blocker, you might get some hypoglycemia. Calcium channel, you might get some hyperglycemia. DIG, you may have an elevated K. Alpha, you may have some hypothermia and meiosis. So you fully entrust the patient and find 3 patches on the lower back. And so babies find little stickers and they say, ooh, fun, let's put it all over. And unfortunately, you don't know until you undress the kid, which is why we always expose our patients. So clonidine's an alpha-2 receptor agonist. You can get bradycardia, hypotension, hypothermia, meiosis, CNS depression, and some Cheyne-Stokes respiration. Obviously, best thing to do, take off the offending agent if possible. If it's an ingestion, activated charcoal. With clonidine, you don't really get any significant electrolyte or hematologic abnormalities, so you won't necessarily see anything on testing. In terms of the respiratory compromise associated with clonidine, usually responds well to tactile stimulation. For hypotension, usually responds well to fluid boluses. And the bradycardia that associated with these ingestions are typically very mild and usually doesn't require therapy, but can always give atropine if the patient's actually symptomatic at a dose of 0.02 mg per kg. And that's it. Just a quick overview of typical ingestions that can cause significant morbidity in children.